Ms. Sobha, for having such a wonderful way of the presenting this particular program. I have to speak, so I will continue with the speak, not another thing. So I'm just sharing my screen. Let me do it first. Yeah. So yeah, I guess it's stop share. Yeah. So hello, very good evening to one and all. I hope I'm audible.
You are audible, Ragini.
Okay. Okay.
Yes,
So,
very much, very much. Sorry, very
so
much.
blessing of God and gratitude to one and all. I'm going to speak how the CVD changes occur during the menopause. We all know that the menopause transition is a phase of changes in everything, maybe a reproductive, maybe endocrinal, maybe a neurologic, or it is a great cardiometabolic transition or two. Menopause is often a turning point for women's health worldwide, and cardiometabolic changes can manifest as the menopausal transition, superimposing the effect of aging onto the risk of cardiovascular disease. So basically, what happened during menopause, we all know there's a visceral fat increase, there's an insulin resistance, dyslipidemia, and endothelial dysfunction. Exposure to endogenous estrogen during the reproductive year provide women with protection against cardiovascular disease, which is last around 10 years post-menopausal. And it is found that women with vasomotor symptoms during menopause seems to have an unfavorable cardiometabolic profile. Early management of the traditional risk factor of the cardiovascular disease is essential. It is important to recognize in the reproductive history of the female specific condition, that is GDM, hypertension, PIH. Some gynecological diseases also, such as functional hypothalamic amenorrhea and probably others, would also enhance the risk of the CVD during and after menopausal transition. I have divided this whole talk in a question answer way. So it is very clear what we want to stress. So why CVD increases at the menopause? Because sex steroids have a profound effect on the many CVD risk factor. Their loss leads to the adverse changes in the lipids, lipoprotein, cholesterol, and there's a reduction in the insulin secretion and elimination, leading to insulin resistance. And these changes in the body fat distribution with accumulation of the visceral fat also link to adverse metabolic changes. And there's an increase of the hypertension, type 2 diabetes, both major risk factor for the CVD. Estrogen have a potent effect on the blood vessels, and their loss leads to the dysfunction of the vascular endothelium. All of these changes result from the loss of ovarian function, contributing to the increase of the development of the CVD. So when the menopause occurs, there's a hypoestrogenism, there's a dyslipidemia, insulin resistance, abdominal fat, visceral fat increased, and all these lead to the CVD. Second point is, what are the risk factors for the CVD and how it's different from the women than men? So we have seen all those established risk factors of the CVD with the obesity and the lack of physical activity. They all have a higher risk in the menopausal woman. And when we see the traditional CVD factor, how they are disproportionate in the CV risk in the woman compared to the men, so we have found that there is increased cardiovascular mortality in women than the men, and increased risk of the heart failure out of proportion to that seen between the diabetic and the non-diabetic men, and higher rates of the coronary microvascular dysfunction and the hypercoagulability and concurrent metabolic symptoms. Not only then, obesity is more prevalent in the woman, and it is an increased independent risk of the CVD. So what is risk difference between men and women suffering from the DM? it is found that in women diabetes mellitus, there is a 1.8-fold increased risk of death from ISD compared with women without DM, and in men, there is a 1.48-fold increase risk. Not only this, women are disproportionately affected by diabetes mellitus. Mortality in diabetic women is 2.1 million versus 1.8 in men. Risk of heart failure is fivefold higher in diabetic women as compared with non-diabetic women. So this risk is appear multifactorial. Women have higher rates of the coronary microvascular dysfunction, hypercoagulability, and increased expression of the concurrent metabolic syndrome. Fourth, what is the effect of obesity on the CVD in menopausal women? Obesity, another traditional CV risk factor, is more pronounced in the women than in men, and it has shows increased risk of the CVD in women. The Framingham Heart Study, for example, found obesity to increase relative risk of the CAD by 64% in women compared with the 46% in men. So higher levels of activity may be associated with the lower rates of the chronic disease such as CVD. This may also be adding to the increased CV risk for the women they face. Now, effect of hypertension differs in men and women. How? Hypertension is another well-established risk factor for CVD and leading cause of the CV mortality worldwide. Women with hypertension have a higher population-adjusted cardiovascular mortality when compared with men and are less likely to be treated to guideline-directed blood pressure goals. Postmenopausal women are particularly susceptible to this as estrogen levels decline. So do is the protective vasodilatory effects and resulting benefits to the blood pressure. What are the future CV risk factors unique to women pertaining to pregnancy that we have discussed? The woman who has a GTM, preeclampsia, those women have more of the CV risk during the menopause. So it is very, very important when you have those patients, you have to focus on these things also. Why PCOD patient has more of the CVD risk? It is found that the most common endocrine disorder in young women, that is PCOD, they tend to have insulin secretory defects and insulin resistance, predisposing to them to the metabolic syndrome, which is known to be associated with the CVD. The coronary artery risk development in young adults study reported a fourfold increase in the coronary artery calcification in PCO patient when compared with the general community. Next point is what is the relationship between the autoimmune disorder and the CVD risk in the woman? We know that the systemic autoimmune disorder represent another category of the CVD risk factor, and females are as 2 to 3 times more likely to develop the rheumatoid arthritis than men, and 9 times more likely to develop SLE. Systemic inflammation seen in these autoimmune disorder has been linked to the atherosclerosis and the CVD, and evidence suggests that the more active autoimmune disease measured by the frequency of flares heralds a worse CV prognosis. So what is the relationship of the age of menarche to the CVD? The age at which women experiences menarche may also play a role in predicting risk for the CV events. Increased risk is observed in patients who begin menstruating early or late. UK population-based million women study suggests that the both early and the late age at menarche predict a higher risk of the adverse CVD. Similarly, women who started menstruating more than 15 years had a hazard ratio of 2.5. This trend also seen after adjustment of the multiple CV factors. Next point is what is atherogenic shift in the lipid profile in menopause and how it leads to the more risk for the CVD. So menopause has shown to be associated with the more atherogenic shifts in the lipid profile. After menopause, women are noted to have a higher total cholesterol, triglyceride, and the LDL levels in addition to the reduced SDL level. In the study of women across nation, LDC and the apolipoprotein B in particular, when compared with other common CV risk factor, were the only two factors to change in association with the menopause, not just the age. What are other changes in the heart, which are considered a predisposing factor for the CVD? So postmenopausal women are at higher risk for the heart disease due to greater volume of a type of fat that surround the heart. There are two types of the fat that surround the heart are epicardial fat and the paracardial fat. Pericardial fat found outside the pericardium increase the risk of the heart disease in the postmenopausal woman. This type of the heart fat linked it to the risk factor of heart disease shown that menopausal status and the estrogen levels are the critical modifying factor for its associated risk in the woman. This pericardial fat is located outside and have no heart protective function of this fat is given. In literature, it was found that the greater pericardial fat volume was not only linked to the lower levels of the estradiol, but it is also associated with a greater risk of the coronary artery calcification, which is an early sign of the heart disease. So the volume of the heart fat can be reduced with a heart healthy diet or the bariatric surgery. The research team plans to conduct a study on the impact of the hormone therapy also. So what tip you want to give for a healthy heart diet? We all know, discuss many times that the factor food to include the fiber-rich food and healthy fats and include high quality of the protein with the lean meat, poultry and choose skim milk and yogurt and avoid packaged food, processed food and the avoid convenience food. So what are the systemic effects of the estrogen? Estrogen regulate a variety of the systemic factor. They can alter serum lipid concentrations, coagulation in the fibrinolytic system, antioxidant systems, and the production of the vasoactive molecules such as nitric acid in the prostaglandins. So estrogen can have a direct effect on the vascular cells tissues enacted through both genomic and the non-genomic pathways. I have given only 10 minutes. I'm not going in the detail. But we all know that the estrogen effect on the vasculature can depend partly on the extent to which atherosclerosis has been established in a given vessel. Estrogen's potential anti-atherosclerotic effect may be less robust in diseased arteries, and not only has existing atherosclerosis shown to result in the diminished estrogen receptor expression, but the effects of the estrogen itself may have a different consequences. So what is the role of the menopause therapy in CVD? Beneficial effects of the MST occur only when therapy is initiated early in the menopausal period prior to the development of the advanced atherosclerotic disease. In healthy women within 36 months of the menopause, therapy in the KEEP history did not prove to slow the progression of the CIMT or of XCAC, and treatment did improve mood, sleep, and vasomotor symptom and bone density, suggesting that there may be a non-cardiac benefits and safety in using MST in the recently menopause women. So next point is, if there are any benefits of the MST on the CVD? MST is effective in reducing vasomotor and the genitourinary symptom associated with the menopause, promoting bone health. A Cochrane review including 24 randomized controlled trials studying MST administration for the vasomotor symptom demonstrated a reduction in weekly hot flashes by 75% and demonstrating it may be an effective therapy for difficult to manage symptom of menopause, which on its own is associated with the increased risk of the CVD. So MST is currently approved by the FDA for vasomotor, genitourinary symptom, prevention of the osteoporosis, and is a replacement in setting of the surgical menopause, but not for as such for the any CVD. What are the guidelines for MST? Patients with vasomotor symptom who are less than 60 years old and within 10 years of the menopause onset are healthy without contraindication can be given. In patients who are more than 6 years, more or 10 years, risk of MST outweigh the benefit. So we should not think that MST have a role in prevention of the CVD. So how do you optimize CVD risk in the woman prior to initiating MST? So considering the MST, we have to have a general lifestyle recommendation along with the less than 60 and less than 10 years of the menopause. While MST is not recommended for primary or secondary prevention of the CVD, pre-existing CVD risk should be assessed in all women considering these therapies prior to initiation. To conclude, CV risk in women increases at the time of menopause, likely related to a combination of aging and the menopause transition. Proper CVD risk assessment is imperative for improving long-term CVD outcomes, guiding risk reduction therapy, determining safety of MST if needed. A thorough history of the adverse pregnancy outcomes and complication is required in all perimenopausal women. Assessment of the family history of CVD in addition to any personal history of autoimmune or the rheumatological disorder or HIV is essential. All traditional risk factors should be assessed as well as current lipid cholesterol level, blood glucose level, and the blood pressure. All women should receive education on ideal body weight, a plant-based heart healthy diet, and the optimal exercise routine. MST is not recommended for primary or secondary prevention of the CVD. In select population, the woman may benefit from its vasomotor, genitourinary, bone health effects. Principal underlying safe use of MST include using low-dose MST for shortest possible duration and employing transdermal, SERM, and the topical formulation where appropriate. It is imperative that both patient and the providers are aware of the appropriate indication for MST and individual risk. Several calculators are available to further risk stratified in this patient and enable safe shared decision making such as ASCVD pooled cohort risk calculator and the NAMS MinoPro app. I think these risk factors will be discussed by our guest faculty today. Quality of life for the postmenopausal woman is an important consideration and in addition to early risk assessment and the CVD risk reduction. Decision regarding MST should be made individually and reassessed over time. Thank you so much for the patient hearing.
Thank you, Ragini. Thank you for giving a kind of overview of cardiovascular concerns in aging women, in midlife
And
women. I
in
shouldn't
time also,
say
within
aging.
10
Yes.
minutes.
Yes, thank you so much. I will now invite Dr. Ananthraman to give his perspective. And I had asked him to essentially speak on primary prevention of cardiovascular illness in women, cardiovascular disease in particular. And with his vast experience, I think it was very tough for him to crystallize his thoughts into a PPT of 20 minutes, but he has done that for our sake. Can I briefly introduce, sir? Can you please give me his CV, Paresh? Kindly share and also open. Yes, Paresh? Hello? Hello? Yeah. So, okay, so it will be very difficult to read out a 9-page CV when the talk itself is of 20 minutes. But then we have come to know Dr. Anantram as a very, voracious, very, very strong advocate for women's health in in the city of Bangalore. He is I have had the good fortune of visiting this center, and I can see that his work is really refined and clinically excellent. No, no, I have not done. Mainly, it is the first page only. Paresh, please don't go up. Yeah, please don't go up. Yeah, no, please. He's an alumni of St. John's Medical College, Bangalore. Yeah. And he is a consultant endocrinologist and co founder of Magna Clinics for Obesity, Diabetes, and Endocrinology, as I said. And he is visiting consultant at other hospitals in Bangalore as well. Can you go up a little bit? I just wanted to highlight that amount of research work and the amount of publications, the number of publications that have happened through him. And also, he has led the local endocrinology society and has been a co-investigator in almost 15 clinical trials in almost every new molecule which has come for the management of diabetes and obesity. And we really wish you all the best for your brilliant future, Dr. Nantram. And also, we welcome you here to this forum of Indian Menopause Society. And I shall now request you to share your presentation and deliver your lecture. Thank you so much. You can
Thank you,
stop
ma'am. Thank you
sharing.
for,
Yeah.
yeah. Thank you for those kind words, ma'am. And I hope I'm able to live up to the expectations. So I'm going to speak today about primary prevention of cardiovascular disease in midlife women, risk assessment and possible solution. So since uh, the segment itself is a prescription workshop, so I'll try to go through the the why of it, and I'll try to go into the how of it actually. So I've not focused. I don't have too many slides on the how of it, but I'll tell it. So because that's what I do every day. So it's the day-to-day thing what we do. So one thing we have to understand is that though we focus a lot on cancer, so CVD kills more women than all forms of cancer combined. And sharp rise in CV risk occurs during menopause transmission, independent of other risk factors. So when a woman reaches about 45 years of age, so independent of chronological age, there is a jump in the risk. So if someone enters menopause at say 38 or 39, the cardiovascular risk goes up starting 38, 39. It doesn't start going up at 45. So it's not age dependent, it is actually menopause transition dependent. And CVD is very important because it's by far the number one enemy for all human beings, and equally so for women. So very often we think that breast cancer, we talk so much about whether breast cancer is a number one killer. No, it is not. It is actually cardiovascular disease, and cardiovascular disease is eminently preventable in primary care settings. So each of us, practicing in our clinics, where we see routine day-to-day patients, we can do something about it. Whereas, breast cancer prevention, though it is very important, many a times we don't have the expertise or the bandwidth to do it. Many of the things that we're going to talk about today in this prescription, all of us can do it. So it's easy for us. So if you look at the National Vital Statistics System of CDC, it says that the consistently shown that the heart is the number one cause of death in women in the US. So if you look at the global burden of disease survey, which is worldwide over 200 countries and territories. So this is really a global representative sample. Data consistently shows that ischemic heart disease and stroke are among the top causes of death for women worldwide, irrespective of whether it is developed country, underdeveloped country, etc. The American Heart Association ESC also similarly echo these kind of findings. So it's very, very important. Cardiovascular risk reduction is important for us personally also. So all of us are above, say, 40, 45 years. All of us, it's important for us also to learn about this. So the CV risk. So what we see is that there is a change in trajectory of cardiovascular risk. I think the previous speaker, Rajni Madam, has also alluded to it. So, because of estrogen deficiency, there is a rapid worsening of atherosclerosis that does occur. So, when you actually, impose it on a graph, so if you see this dotted line is a theoretical risk attributable to aging alone, due to age alone. The red line is due to the risk due to menopause actually. So when menopause onset occurs, so there is a rapid jump in the risk profile. So patient is on a different uh, uh, you know risk profile increase based on age. Then menopause onset happens 2 years before menopause. So the arterial stiffness increases by approximately 7.5%, suddenly starts increasing by almost 7 times more than usual. So the usual increase is 0.9% per year because of age alone, say between the age of 25 and 35 or 40. So it goes up by 7.5. And there are lots of lipid changes also. LDL cholesterol and apolipoprotein B sharply rise during the menopausal transition. And the scientific consensus says that menopause transition and cardiovascular risk confirms this period as associated with a distinct acceleration of CVD risk. So there can be two approaches to this. See, one is, we can give menopause hormone therapy early. I think Dr. Shobha will speak about it later, about menopausal hormone therapy as a cardiovascular protective intervention. But there are conventional interventions which physicians, as a physician, as an endocrinologist, so all of us do, internal medicine, nephrology, cardiology, endocrinology, all of us do preventive intervention, primary intervention. So for all our patients, and including family physicians also are doing, this primary prevention. So what all can be done is the crux of today's talk. So the biology of the transition has been alluded to in great detail. I'll not go into it. There is an upward shift in the LDL and ApoB. There is also an increase in visceral adiposity. Which comes first, we don't know. Whether visceral adiposity comes, then the LDL and ApoB goes up, or the LDL ApoB goes up first, we don't know. Consequently, there is an increase in insulin resistance also, and the endothelial dysfunction also begins. So let us look at how we can do a precision risk assessment for a patient with cardiovascular disease. So when you look at risk assessment, now there are statistical models derived from various long-term epidemiological studies. So we have the ASCVD risk scoring by the ACC AHA, which is the most popular one. So all of them will incorporate many risk factors: age, gender, cholesterol, HDL cholesterol, LDL cholesterol, systolic, diastolic blood pressure, smoking status, diabetes status, hypertension treatment, family history of CVD. So there are ready-made risk engines which we can use to calculate the risk level. So we can classify the patient as having low risk of cardiovascular disease, or intermediate risk of cardiovascular disease, or high risk of cardiovascular disease. These are three broad baskets in which we can include a patient. So just because a person is entering menopause does not mean that they are at high risk automatically. Other aspects also matter. So age, of course, will be high. Gender, of course, it's female. So, but their LDL level may be very low. If someone's LDL is, say, only 60 or 70, and their blood pressure is absolutely normal, they are non-smoker, they don't have diabetes, they don't have hypertension, then the risk is very low. So when you key all these things into the risk profile, there is a Q-risk calculator is also available. Q-risk calculator is actually developed by the British. So it incorporates Pakistani and Bangladeshi and Indian subjects also. So it is more specific for South Asians. Then we have the Framingham risk score. I think ma'am had spoken about this in the previous talk about the Framingham risk score. But Framingham risk score is mainly for coronary heart disease, CHD. Whereas other ACC AHA risk score, the PCE 2013, the score to all these are risk scores which incorporate a risk of both heart attack and strokes as well. So certain risk scores have got migraine also included basically. So when you look at PCE, minor risk factor is migraine. So, some risk scores include erectile dysfunction for men, of course. So, and most importantly, there was a publication from AHA and ACOG combined publication which looked at all these things, but they don't have a specific risk marker for postmenopausal women per se. We have to use the or perimenopausal women per se. We need to use the conventionally available risk engine. So this is a method of this is I have calculated theoretically. It is online. So the risk ASCVD risk calculator is there. I can share it later. I'll put it in the common group, the link, so that you can use it. And this is available as an app. The ACC AHA risk calculator is available as an app, as a desktop tool also. So you have to fill all these things: blood pressure, total cholesterol. So if you have a healthcare provider or an assistant who can do it, or you can do it yourself during consultations. So once you fill it, you will get an risk score. So you can see that 3.9% is low. So based on the risk profile of the patient, we decide whether the patient requires statin or not, whether the patient requires BP lowering drug or not, etc. So if somebody is classified as high risk, they will require high intensity statin. Moderate to high intensity statin, they'll require good control of blood glucose. They'll also require aspirin therapy. Sometimes aspirin therapy, usually we don't use it as primary prevention anymore, but in select cases, where we feel that it's a very high risk, we can use it in primary prevention, but on an individualized basis. So hypertension has to be adequately treated. We can treat hypertension to a level of below 130/80. So it's a multi-risk factor treatment. So we need to treat the blood pressure, blood sugar, lipids, and then the weight also. So using GLP-1, we can bring down the weight as well. That's the latest intervention that has been shown to work beautifully. So when you look at the female specific risk enhancers, specifically for gynecologists, so this is something that you will have in your file already. Any evidence of adverse pregnancy outcomes like preeclampsia, gestational hypertension, or gestational diabetes, or a preterm delivery would indicate that the person is at a high cardiovascular risk. So premature menopause is also a cause for high cardiovascular risk. Autoimmune diseases like rheumatoid arthritis and SLE, highly prevalent in the premenopausal age group, say 35 to 45-year age group, is also a risk factor for cardiovascular disease. So it's very important to note that preeclampsia doubles the risk of future cardiovascular disease. It indicates that there is a level of endothelial dysfunction. So there are certain other advanced screening tools. So the basic screening tool is accessible to all of us. So all of us, all our patients can get a lipid profile. All our patients can get a clinical examination and a history. So based on this, and also we will know their blood glucose because most of them usually get their annual workup done. So we will be able to do a conventional risk scoring for almost all our patients. The ACC AHA risk score or a Q risk 3 is what I would recommend, and I use in my clinical practice also wherever I need to motivate a patient for a statin therapy. In clear cut cases, in diabetic patients and all, they automatically become moderate risk candidates. So directly we'll put them on statin therapy. So wherever there is a doubt, whether, when a person is looking absolutely healthy, but we have a doubt that this patient or the patient themselves, they are asking, I want to be evaluated for cardiovascular risk, then we can do something called a coronary artery calcium score. So if the CAC is zero, it is low risk and no statin is required for the next 5 to 10 years. If the CAC is greater than zero, statin therapy is favored. If CAC is more than 100, statin therapy is positively indicated. So it visualizes the actual blood vessel which supplies the heart. So it's a more proximate measure. We can do other measures as well. We can do measures like this carotid intima media thickness, CIMT also. So where we can actually assess the atherosclerosis in the blood vessels. So the best way to know how blood vessels are in the heart is to look at some blood vessel. So if you insonate the carotid artery and measure the carotid intima media thickness, you will know that this particular individual is having atherosclerosis and is likely to have a atherosclerotic event. Another advanced screening is lipoprotein little a. The ESC guidelines recommend measuring lipoprotein little a at least once in a lifetime for individuals. If someone's lipoprotein little a is greater than 50 milligram per deciliter, it's a significant risk enhancer. Similar risk enhancer is actually the family history of cardiovascular disease. In my clinical practice, I take history very often, and if I find that the patient has say 130 LDL, patient is deciding whether or not take statin. One of the crucial differentiators, where we should tell the patient, see, look, madam, you are at risk for cardiovascular disease because your family history is bad. Like if their brothers or if their father or uncles, they've had a heart attack or a stroke at a young age, say less than 60 years. For males, it's less than 60, less than 50 years. For female, less than 60 years in their first degree relatives, then it's a premature coronary artery disease. So, or premature CVD. Even a stroke also will fit into a premature CVD. That's a soft risk enhancer. So if it is there, usually, then we need to treat such a patient. Of course, smoking cessation is the most important lifestyle intervention. I've not spoken about it, but when you play around with the risk engine, so you fit in smoking, non-smoking, it will make a huge difference. Some people who are classified as low risk, once you add that they are smokers, it directly will go to intermediate or high risk. So it increases the risk profile. So whatever risk, 10-year risk was 3% risk of heart attack or stroke, now will directly go to 10% actually. So the increase in risk is almost 3 to 4 times when someone smokes. So smoking cessation is the number one intervention when it comes to cardiovascular risk reduction. So when it comes to diet, what kind of diet? So I've stuck to only the interventions which are proven by randomized controlled trials and proven. So there are so many things. Everybody says that there are so many different interventions. So when you open the internet, you will find a host of advice on what we can do to reduce the risk of heart attacks. So what I am sticking to is basically the class 1 level A indication. So Mediterranean diet is recommended to be a cardiovascular protective diet. It reduces the risk of CV events. So please note that there are various types of diet that a person can do in order to maintain weight. Many people do a one meal a day diet. Many people do a keto diet. So all these don't reduce cardiovascular risk. They may be improving blood glucose, they may be improving blood pressure or weight, but they may not be improving cardiovascular disease. One needs to understand that one is not automatically leading to the other. So, supposing a person reduces weight, it doesn't automatically mean that their cardiovascular risk will also come down. So there are a lot of effects due to diet itself. So, the antioxidant property, the anti-inflammatory property of the diet itself may be responsible for cardiovascular risk improvement. So there was a RCT called the Predimed trial, which looks at a 30%, which showed that there is a 30% reduction in major CV events and superior to low-fat diets for cardiovascular prevention. So weight management again is important in CV risk reduction. Central obesity is a central driver for cardiovascular risk more than 88 centimeter. I'll come to this when I talk about GLP-1 agonist as an intervention to prevent cardiovascular disease. So comprehensive lifestyle counseling is what is recommended initially for patients with central obesity or any obesity. So typically we should use central obesity more rather than the BMI itself. So because someone can have a BMI of 24 and have a significant central obesity, waist circumference can be 90, 94, etc., abdominal obesity. So those individuals will be at high cardiovascular risk. We should advise diet, exercise, and behavior therapy. Then we should give the goal as waist reduction also. The goal should be 5 to 10% weight loss, which yield a significant reduction in blood pressure and lipids. GLP-1 agonists are emerging as a major intervention in weight management. So weight management, I think many of your patients will ask about this, or they may be already taking it from the physicians. So it's very important to know about it. So I think we have spoken about the SELECT trial data, which shows that cardiovascular prevention can be one of the goals of GLP-1 therapy, not just weight loss. Weight loss is fine, whereas for people of this age group, weight reduction is not cosmetic requirement; it is actually a survival requirement. So let us look at hypertension management, how to go about and what should be the target. So definition of hypertension is 130/80, the ACC-AHA 2017. For most patients with CVD, the goal should be less than 130/80, class 1 level A indication. Class 1 level A indication. So pharmacotherapy is indicated when the BP is more than 140/90, and the goal should be gestational. If there is a history of gestational hypertension, it's a strong predictor of chronic hypertension, and we should monitor the BP closely. Someone who has PIH and even after delivery, we can inform them that regularly check your blood pressure, show to a physician, or you can self-monitor the blood pressure. We can tell them that self-monitored blood pressure values of more than 135/85 will require therapy. I inform this to all patients and I encourage them to check the blood pressure at home. So many will do it. Nowadays, BP monitors are widely available and patients can do it by themselves. If you just give one word, so just write that in your prescription. Monitor your blood pressure regularly, and if it's more than 135/85, return back to us. That is enough. Another prescription that we can do is LDL lowering. It's very easy. So we can prescribe atorvastatin 10 milligram or rosuvastatin 10 milligram. So when do we prescribe this? Directly, irrespective of age, if the LDL is more than 190. If someone has diabetes and the age is between 40 and 75, we start moderate intensity statin therapy, which is basically rosuvastatin 10 milligram or atorvastatin 10 or 20 milligram. In intermediate risk patients, we can give a moderate intensity statin. We can favor a lower intensity statin like a pitavastatin or a simvastatin. But typically, almost all patients would get statin therapy. And why statins are such a hit is because they are very, very effective in cholesterol lowering. So, in fact, I can, even before asking the patient whether they are actually taking the tablet or not, more or less, I will know whether the patient is taking the statin or not. Almost all patients who take even a small dose of statin, say 5 milligram, 10 milligram, LDL will be always below 100. So, they are very, very effective in bringing down the LDL cholesterol. When compared to diet, they are highly effective. It's amazing how effective it is. And it has made a huge difference for cardiovascular prevention. So, if the patient has a diabetes or has a intermediate risk, we need to start a moderate intensity or a high intensity statin therapy. And if they've had a risk enhancer like preeclampsia, and then we find that we fit in the we make the risk calculation and we find that it is moderate intensity, we should start them on statin immediately. So in the prescription, you can actually add a statin, and statin does not have any side effects. I'm yet to see a patient who has had a significant statin side effect where the patient had to be admitted to the hospital. Sometimes there can be skin rash, that also maybe one in 10,000, 1 in 15,000 patients. So I've seen maybe more than about 35, 40,000 patients in the last 10 years. I'm yet to see a single patient who's admitted to the hospital because of statin therapy. But whereas I see patients every day who's admitted with heart attack and stroke, isn't it? So it's an obvious no-brainer. Anybody can start it. I think when you are looking at patients where you feel that there is a high risk of CV risk, somebody is extremely obese, very high blood pressure, you can start the statin yourself also. Aspirin is again no longer recommended, and it used to be recommended before, and now it has been used for select high risk patients with a very strong family history and a low bleeding risk, and this requires a shared decision making. So aspirin, so we can cut down the prescription. So in this prescription workshop, we can say aspirin is out of your prescription, statin is firmly into your prescription, BP reduction is also firmly into your prescription. So, of course, physical activity is very, very protective for cardiovascular disease. 150 minutes of moderate intensity physical activity, strength training, and also it is useful to record the exercise minutes as a vital sign in order to reinforce to the patient that you have to be exercising. So when some patients come to you repeatedly, so in addition to pulse, BP, and blood pressure, we can record it as exercising, not exercising, exercising adequately, exercising not adequately, like that. So this will motivate the patient to do exercise. Strength training also is very, very useful. Coming to GLP-1, so you can see that almost all GLP-1 based therapies have been shown to reduce cardiovascular risk positively, and majority of that has been in the secondary prevention. So if you look at secondary prevention, today we are talking about primary prevention, those who have not had a heart attack or a stroke. So of course, those who already had a heart attack or stroke already have a cardiologist, they are going to the cardiologist, and that person will focus their attention on the cardiovascular health issues, they'll give treatment. I'm talking about the general public who come to us, so to go to gynecologist for menopause care, or some other gynecological issues, or they come to endocrinologist for routine care of their diabetes or hypertension for preventive care. So in those individuals also, in primary care also, so if you look at dulaglutide, it has been found to be useful in secondary prevention. So if you look at the SELECT study, which was actually a 100% secondary prevention. So it's a trial result which came out last year, where injectable semaglutide has been used as an intervention in post heart attack patients. Okay, so and in post heart attack patients, these are patients without diabetes with only obesity. Okay, so these are patients who had an MI, admitted to the hospital. In addition to the doctor telling you have to reduce weight, you have to do exercise, you take the BP medicine, you take the statin. These are non-diabetic patients. Semaglutide was used in these patients, and there was a 20% reduction in cardiovascular events, which is phenomenal for this molecule, which shows that this drug is a cardiovascular drug also. GLP-1 is a cardiovascular drug, and this is something that will add to our armamentarium. So the degree of risk reduction, what we see with semaglutide, is on top of already statin, blood pressure lowering therapy, and also optimal glycemic control. So in these patients, they were non-diabetic, of course. So even in the diabetes space, we do find that there is a cardiovascular risk reduction. So there is a phenomenal improvement with GLP-1 based therapy. So my take home message will be, in perimenopause is a time of heightened CV risk. Basic evaluation and sensitization will improve outcomes. Interventions are highly effective and life prolonging when used cumulatively. It is not one intervention that will cause cardiovascular risk reduction, but when you use all of them together, you reduce the blood pressure also, you give a statin also, you control the blood sugar as well, you reduce the weight using the GLP-1 or with diet and exercise. When you do all this, of course, Mediterranean diet, if the patient is able to do, that's great. In fact, among all the interventions, the most difficult ones to prescribe are actually the diet and exercise, because the patient may not be able to do it. They may not be able to afford it. They may not have the time. But whereas the pharmacotherapy is very accessible for all of us, that's why I like the topic of today's seminar, which says that, it's a prescription workshop. So for every patient, you can, when it comes to antihypertensive therapy, we should use the ARB, telmisartan, or we can use a ACE inhibitor also. You can use a perindopril or a enalapril. So these are the drugs of choice for preventing cardiovascular events, basically. And they also have shown cardiovascular risk lowering similar to that of GLP-1 based therapies, though they are very old
mm,
molecules. We've been using it for years together. So
mm.
pharmacoprevention, in given at the right time and with proper sensitization of the patient, will make sure that the patient will actually take it, and we can probably reduce cardiovascular risk substantially. Thank you.
Yeah. So that was a wonderful, crisp talk, and without wasting a single second, you have, bullet fired all the information to us. Dr. Anantram, one of the questions is, because I also have a few questions. One question which has been asked is the duration that statin should be given, and it
Mm,
can
mm, mm.
add, can be given, whatever. Please answer
No,
that.
what I tell all patients is I never use the word lifelong treatment actually.
Mm,
So
mm.
because people get upset by that actually.
Yeah,
So
psyched, correct.
so actually psyched by that. So what I
Mm,
tell them is, you may have to use it till 65 years or 70 years. I give them an end date actually. Okay. Someone comes to you at 45 years, they'll ask how long I should take this. So I'll tell them you
But
take it for
is
20
that
years.
a
Yeah.
truism? I mean, is there truth in that?
It
Is
is
what
true.
because
It
we
is
are on
true.
this side of the table, so we want to
Yeah,
know.
yeah. 40 to 75.
Uh,
It is 40 to 75. You're supposed to give it till 75. There is evidence up to 75 because we have not been able to enroll people into RCTs beyond 75.
mm,
There are
mm,
very few elderly because very
okay.
difficult to enroll people of that age group into the trial because there are so few of them available actually.
Yes,
So,
yes. And what about
so
why exactly did ecosprin go out of the picture? Aspirin go out of the picture? Because in obstetric risk reduction for preeclampsia, it is getting
mm.
reinforced every day,
Madam,
So why did
it's the
it go
question of
out?
risk benefit ratio, ma'am. So basically, what they found in large primary prevention trial was that the bleeding risk was similar to that of the cardiovascular risk actually. Okay, so this
Oh,
we have to handle it sensitively. If a patient is already on aspirin, I never withdraw the aspirin, ma'am.
mm. Yeah,
Okay,
that's what
I
I
think none
wanted
of
to
you
know.
should also
Mm,
do it. If the patient is
correct.
already on aspirin, there is
Mm,
nothing to say that you withdraw the aspirin because that will happen. What will happen is these patients may be preventing the aspirin may be
mm,
preventing a cardiovascular event in such patients. In fact,
mm.
it happened to one of my close friend's father. I withdrew the aspirin and the patient had a stroke and heart attack
My
and a
goodness.
stroke
That's
together.
what.
He was elderly gentleman.
My goodness.
So I mean, by experience not to do such things actually.
No, the thing,
So
yeah,
yeah,
the
yeah.
thing is
Mm.
that now it has been there for so many years, and
Mm.
suddenly, let's say, because also if they are doing well on aspirin
Yeah,
without
if
any
they are
side
not
effects,
having any bleeding, we don't need to
correct,
stop it. If they are
correct,
having bleeding, you
exactly,
stop it. Mm.
correct.
If they
So
are
that
having
is
troublesome
another thing.
bleeding, if they are having GI bleed, if they are having
Yeah,
perrectal bleeding and all that, or
correct.
if you are having to stop it because of various interventions, surgical
Mm,
interventions where
mm,
there is a bleeding risk, you
correct.
can stop it. So we
Mm,
can liberally stop it before cataract surgeries and other things. Some people say, you don't need to stop the aspirin. You do the cataract surgery or something. I don't believe in that because
mm,
even if there is a small risk of bleeding during surgery, I don't want the
yes,
patient to
yes,
have that risk because
correct.
stopping the aspirin for 10 days is not going to elevate the cardiovascular risk in those days
Yes,
actually.
yes, agree.
So
And
No,
one question, yeah.
okay. I have one
Eh,
doubt.
huh,
Lean patients, any problem with the statins?
not at all, ma'am. Madam, statin is being given to reduce the LDL cholesterol directly, and
Mm,
lean or obese, it will work, ma'am. And
okay.
also, weight reduction per se is not a very consistent way to reduce LDL cholesterol. That's why statins are still there.
correct.
So even trial after trial have shown that even when you reduce a lot of weight also, say some people lose 10 kg, 15 kg weight
Mm,
also. Even we have patients on GLP-1 now who lost
mm,
10 kg weight, but their LDL is high.
mm.
So it is dietary and it's very difficult to change
It
the
seems
diet.
to,
Mm,
correct. Just one observation I had, Anantram, I don't know whether I am right, but it looks like the Indian subcontinent or ethnically, there is more dyslipidemia in terms of higher LDL, which is independent of weight. I've seen
mm,
many
mm.
lean people also with dyslipidemia.
It's very common,
Uh,
ma'am. It's very, very
yeah,
common.
so it
Yeah.
has
And
to do
also,
something
yeah,
with the.
familial hypercholesterolemia is the most common Mendelian genetic disease.
Okay, okay.
So it's very, very common. and it is being recognized now very commonly because we do a lot of lipid profile. So earlier it used to be very costly. So I remember during my undergraduate days, so professor used to tell us, it's very expensive to do a lipid profile. It costs 400 rupees. Even today, after 25 years, it's 400 rupees. So the cost has come down manifold. So that has actually led to a lot of testing, and which is as it should be. So because unless patients have access to that sort of thing, it's very difficult.
One more question is
One question from
any
my
risk
side,
of
Dr. Anand.
sarcopenia or liver dysfunction? यही last है मेरा रागिनी ये
Dr.
just
Anand?
हो गया.
One question, what you will see about the high triglyceride or only focus on the high LDL?
Yeah, triglyceride
Ma'am,
was my question also, correct?
yeah. So, ma'am, I'll explain this. So, there have been a lot of trials which have been done looking at triglyceride lowering as an intervention to reduce cardiovascular events. So, none of the trials have shown positivity in the primary outcome, that is, whatever they set out to achieve. So, high triglyceride and low HDL, what it does is it makes the LDL small and dense, basically. So even though the high triglyceride is a marker of cardiovascular risk, so the better option seems to be to just simply reduce the LDL in a nutshell. So we can
If a
reduce
patient
LDL through
has a
statin.
triglyceride in tune of 750 and LDL is not very raised that 101, 102, what it does mean?
Ma'am, it means that there are two things, ma'am. If the triglyceride is more than 500, it's a risk for pancreatitis. So we need to bring it down, that level of triglyceride. And also this patient is at high cardiovascular risk. So we should give a statin to bring the LDL down to below 70. And we should give the triglyceride lowering drug to bring the triglyceride below 500 or 400.
Correct.
That should be the target for that patient. So that should be that's the clear mandate as far as this thing is concerned. They have done a lot of studies looking at increasing the HDL, reducing the triglyceride. None of them have worked. But whereas all LDL lowering drugs, irrespective of the agent use, has been positive for cardiovascular risk reduction. One is your statin. Then we have ezetimibe, which has also shown risk reduction. Then we have this TCP7, this once monthly biologicals, which are PCSK9 inhibitors. So those are also effective in LDL reduction. Then we have something called bempedoic acid, which is again effective in LDL reduction. All of them have shown cardiovascular outcome improvement. So there used to be a doubt before whether the cardiovascular improvement is due to LDL lowering or it is due to the statin itself because of the other beneficial effects of statin. Now it's very clear. It is settled science now actually. So it is actually only LDL lowering.
Okay.
So
Very
the
clear
target now
message.
given is actually below 45 LDL
My
for
goodness.
people who have recurrent cardiovascular disease.
Okay. But
Is
primarily,
is semaglutide an ideal drug in obese diabetic patient to reduce the CVD risk and reducing weight and
Yes, ma'am.
triglycerides?
It is the ideal. It is whenever somebody has high cardiovascular risk, the ADA recommends that you use it first line, a GLP-1 agonist. It does not say semaglutide, it says GLP-1 agonist. So because in our country we have liraglutide also, which is much less expensive, but it's a daily injection. So, but hopefully by April of this year, I think just like how all of our patients have access to statin, then enalapril and telmisartan, so they will have access to weekly semaglutide also. Once that happens, I think almost all of us will have to use it in all patients. So literally,
yes.
so it's just a
We
question
are
of
also looking for that.
how to
Yes.
use it. Yeah.
Correct. We are also looking for expanding horizons on that. And
Dr.
thank you so
Shobha.
much. Yes.
Yeah.
So,
Just this thing. Oh, Dr.
Yeah,
Ramakrishna.
Sudha. Yeah.
It was such
Dr.
a, you know,
Sudha Sharma is the president-elect of Indian Menopause Society. So, Dr. Anantraman, it is very much
yes,
possible
yes.
that you will be sourced again.
Yes, again
Yeah.
and
So,
again.
yeah.
So, Dr.
So,
Yeah, Ramakrishnan,
she is right
it
from
was,
Jammu, across the country from Jammu she is. So,
yeah,
yes, Sudha, please.
yeah,
Yes.
it was such a great presentation, very clear messages. I think no doubts left. I just wanted to know one thing that so much have been talked about, statins and statins. That's what I have learned, or maybe you just correct me if I am wrong. And that's what I have read, that it is probably the most tested and most trial drug over the decades. Does it increase the longevity as well? And you said that, till 75, it is safe to give. But if the person is already on it, should he or she be continuing it, or should he or she be stopping it at 75?
Correct.
Ma'am, it is so we will change the topic when the this thing comes, ma'am. What I do is I don't tell, I never stop the statin in those who are above 75 for sure. But my idea is to get them past the 75-year-old mark, as my
Excellent
responsibility to
response.
society is to do that
Yes.
much at least.
Excellent,
So
excellent.
because what happens is, after the age of 80, ma'am, is that there is a lot of mortality due to infections and all. There is something called immunosenescence post the age of 75, frequent infections, some other things. And also there is a physical decline that happens. So it is not enough if we just prevent the cardiovascular events.
Mm,
So now we know that we have got potent tools to prevent cardiovascular events. So we can improve quality of life, we can reduce this thing. And definitely when you use, madam has asked whether alone statins will prolong life. I don't think alone statins will prolong life, because it's multi risk factor intervention.
Yes,
We need to give the blood pressure medicine, we need to give the statin, we need to control the blood sugar using GLP-1 and SGLT2 inhibitor. Using GLP-1 and SGLT2 inhibitor, not by just giving sulfonylurea. I think even today, majority of physicians are giving glimepiride metformin as first line to patients with diabetes, irrespective of their
yes,
cardiovascular risk profile. When we do all this, then the longevity will definitely increase. There is no doubt about it. So in my own practice, I can see patients who are living, who are had a poor risk profile, doing very well without not going to the hospital. So I proudly tell my patient, I don't work in a hospital. I work in a independent outpatient practice. So I work at a hospital, but that's only for a 1 hour. So I tell my patients that my job is to make sure you don't see the inside of a hospital till you are
okay,
75.
true.
very
So after
nice.
75,
Excellent.
so that is true. So
Mm,
when we reach
Thank
75, we
you.
will see then. So
mm,
the idea is not to stop it at 75,
yes,
but to
not to
convince
stop.
patient, because patients feel,
Correct.
okay, at some 30, on 40-year-old or 45-year-old, ye umar bhar lena hai, they feel that they are going to live forever. So they don't get the idea that our life is finite, actually. So the idea is
Correct.
that you have to hit that 80 years. That's the most important thing.
I think once they meet you, they start believing their life is infinite because they start doing better and better. Thank you so much,
Yeah,
Anantram.
yeah.
Thank
Thank
you
you
for
very much,
that.
Anantraman
That's
sir. It
thank
was
you so
really
yeah.
very, very informative talk. Of course, very comprehensive. One
Thank
thing
you, ma'am.
just I would ask, I would like to ask you that after Corona, that finding that more heart attacks
Yes.
are occurring in the very young age. So,
Correct.
is there any relation or connection after COVID era?
Madam, CV events are occurring in younger patients, but then unfortunately we don't have much of research in this area. So
Mm,
how early to start BP medicines or cholesterol medicines?
mm,
Because our population is slightly different than the Western population. So Asians are tending to get cardiac events even as early as 35 years also. There is a
Yes.
significant number. And also because our population is very large, no ma'am, we'll see all kinds of presentation. I've seen a
mm,
28-year-old girl who got a heart attack, okay,
mm,
less than 30. So between 30 and 40, I've seen so many patients. But even now, if you look at the prevalence, it's about, say, very small number. So if you look at the in the between the age of 30 and 40, what you will do. But basically, typically in such patients, we should look at familial cardiovascular risk. Smoking cessation is very important in that age group, and blood pressure reduction is very important in that age group. Statin therapy, actually, if you look at the any risk engine, it starts at 45 years or 40 to 75 years. Below 40, there is no cardiovascular risk engine at all, because it is not because the people there are not at risk. It is just that they have not been studied. They have not been studied. There have to be dedicated studies done in South Asia, that is in India,
correct. Our
Bangladesh,
population,
our
correct.
population.
Yes,
So where
definitely.
there is a high cardiovascular risk.
Correct.
So what are the drivers? And definitely those interventions will be useful in the younger age group also. So
Correct.
40 to 75 years is not this thing. Even before also we can start. So if you find that someone is at high cardiovascular risk, then that's why even the younger age group, I liberally prescribe GLP-1. So,
Yes.
so of course, diet and exercise is there, but as today's workshop says, it's a prescription workshop.
Correct.
Finally, our dharma is to prescribe. So that if you
Is
do
to
properly,
prescribe.
that's enough.
Yes. The thing
Which
is,
would be the best statin to start?
Meenal,
Madam, we
Dr.
can start
Meenal
either,
Parekh.
yeah,
Yes.
rosuvastatin or atorvastatin we can start, ma'am. Both can be used, and it's widely available.
Thank you.
Dr. Ram, probably as the last question, somebody has repeatedly asked about sarcopenia with statin. Two people have asked, Charan Kaur and Anju Gupta. Yeah.
So sarcopenia, I'm not sure whether it occurs due to statin therapy, but in prolonged therapy, as people get older, sarcopenia does occur, and sarcopenia is a part and parcel of menopause. In fact, there is a muscle loss and bone loss that occurs due to menopause. So the best way to treat the sarcopenia is with strength training 3 times a week.
Correct.
So that is something we should emphasize a lot on, because these drugs, now earlier we never had these good drugs to treat cardiovascular events. Now we have a host of interventions. So we should then focus on strength training a lot for all patients, 3 days a week, strength training, and protein intake, adequate protein intake. So protein intake is not adequate in majority of our patients. So at least 0.8 gram per kilogram protein intake, or you can give one protein supplement to these patients. So both these interventions should combinedly improve the sarcopenia.
Very good. Very good. With
Basically,
we don't
it is
want
myalgia. It is myalgia which occurs with TOVA.
Correct.
Yeah,
There can be some experience more muscle weakness with statin actually,
Yes.
but other patients don't. Others don't. So there is something to be said about individual.
They've done a lot of trials on myalgia. In fact, it's more of suggestion. So they have done a crossover trial where you have a placebo, you have a statin, you give a placebo, you give a statin, like that. So the actual prevalence of myalgia with statin is 1%, similar to that of placebo. So it has not stopped us from this thing, and I have not stopped any patient. I would not say I've stopped very less number of patients on statin. I would say out of 100 patients I'll start, majority of patients stop it because they feel that it's not required. But the most frequent cause of stopping is ignorance, and patient, despite being told, they will stop the statin. Number one. Number two is this myalgia as a reason, but that's fewer than 1%.
I stopped.
Somebody has asked about fibromyalgia and statin.
Yeah.
Ma'am, it may have the muscle pain can have a different origin. I'm not sure whether your muscle pain
That's
will
a different
completely
condition.
disappear with, whether it will disappear with
But
stopping
many
statin. It may
patients
continue.
think
who
we will
are
have
on
to-
statin, they usually when we start, they say that we are feeling very weak and very muscle pain we are having. It is
Ma'am, they say that for
Switching
every,
over to Rosuva helps better.
yeah, we can give pitavastatin. Pitavastatin has got less muscle side effects in trials, but majority of the time patients don't. I never tell the patient that you're going to have muscle pain. If you tell them, they'll complain of it.
I'm
So
feeling
suggestion
that we
itself.
have not given you adequate time because there are 3 more sessions to follow, and we will certainly look forward to another time when we give you the entire time, Dr. Anantraman. Thank you so much.
Thank you, ma'am.
There's a world of information there, and we're very grateful that you could make time. So
Thank you,
with
ma'am.
that, Dr. Anita, shall I move on to the next? Yeah. Yeah, you're muted. Yeah. So with that,
Yeah.
let me go on to the next is, let me share my presentation. And I'm really grateful, Dr. Anantram, if possible, you please be there and then see whether you can add on to our deliberations as well, if you find it's worthwhile. So now there will be a couple of quick presentations on prescription writing, because even Revati madam has requested that she also wishes to show some slides. So I will be very, very quick. And this will be mainly to show the evidence so far for primary and secondary prevention of cardiovascular disease. And there's a lot of confusion about the role of hormone therapy in women who have. Now we realize that almost, many Indian women who reach midlife will have a occult risk for cardiovascular disease, which needs to be to be assessed. And since we are very strong proponents and advocates of menopause hormone therapy for symptomatic women, let us understand the evidence behind it. So when the current need of MHT, we all understand that it is really required for our aging population, and large number of women are menopausal age group today, as 50% of life is now spent. Why are we worried about it? We must be actually propagating it. We feel that there is a reduction in, there may be complications due to MHT, but actually most of the complications which we have outlined here, it kind of gets belittled by the fact that there's a reduction in all-cause mortality when women are initiated on menopausal hormone therapy at the correct time. So if practitioners are worried about stroke and coronary heart disease and DVT and pulmonary embolism, etc., then they need to be reassured that if we select the right patient, there will be benefit and not risk. And it is in our hands to make it a good story and not a kind of complication of CHD at the end of it. So when you look at the estrogen, progesterone and estrogen data in this women in the age group of 50 to 59 years of age, as advocated, less than 60 years of age, you can see that the blue is estrogen here on the right side, and the estrogen plus progesterone is in the orange here. And we see that when estrogen alone is used, then we find a lot of benefits are there. When both are used, then we find that there are a little more higher risk of coronary heart disease, breast cancer, stroke, embolism. But we do see reduction of colorectal cancer in both the groups. We see hip fracture is reduced. We see all-cause mortality is significantly reduced with 5 fewer events in both the groups. And endometrial cancer is actually no difference between the two groups, but actually menopause hormone therapy, whenever it is used along with progesterone, will definitely bring down the incidence of endometrial cancer as well. But then when we look at this entire picture, we also realize that the statistically significant data are still lacking on long-term outcome of MHT. And therefore, we need to be having that courage to prescribe hormones for older women. And for that, we keep on looking for evidence every day. And when we begin to prescribe, then we have this kind of a signal charting, which will help us. And here, if you look at this signal charting, this is approach to initiating MHT. And this is an old chart from American Medical Association, actually, but it still holds good for us. And I use it as a teaching slide, though it might have got updated a little bit. And we go through the assessment vasomotor, the risk assessment. We go through the risk of, we rule out any absolute contraindications like cancers, like cardiovascular disease, already existing cardiovascular disease, or a patient with stroke or transient ischemic attack or active liver disease or undiagnosed vaginal bleeding. If these contraindications are not there, then we divide them into these three charts. We need to avoid whenever there is a high risk of breast cancer or cardiovascular disease, or if the woman is more than 60 years or more than 10 years post-menopause, or there's a moderate risk of breast cancer or cardiovascular disease, these women can be kept out of the MHT pool. But otherwise, we will be able to prescribe MHT to most of the other women. So this is how it goes. for case selection for MHT in general. But when it comes to cardiovascular disease, we are very, very, concerned that we may be kind of pushing the patient more towards complications, and that is what we need to understand today. Now, this is the white paper position statement on which we are basing most of our conversation today, because it looks like this is the international following for the hormone prescription. So quite a lot of adherence to this tells us that there is 5 Ws for prescription, who it is for, what types and doses, when, why is it important, and where it can be accessed, etc. But very important to say that MHT should be given for distressing symptoms of vasomotor especially, and a life course approach is better. As I have spoken earlier, it is important to identify women who have premature ovarian insufficiency, who have risk for osteoporosis, cardiovascular disease, cognitive problems, etc. Smokers in early life, family history, etc. should be checked for. And then we have to reiterate that regular exercise will reduce the risk of early menopause, and therefore such women should be promoted to have an active lifestyle. The question is whether medically high-risk women should be prescribed MHT. There is a role for relief of symptoms versus potential risk of MHT. So whenever quality of life considerations are there, it's important that we do consider MHT for people with high risk. Hormone receptor positive breast cancer and endometrial cancer, in general, it is contraindicated. Rarely it is when early stage cancer is treated. Then maybe for GSM, that is genitourinary syndrome of menopause, the MHT must be considered with local estrogen, and past history of venous thromboembolism, possibly we should consider transdermal estrogen in them. So these are some of the examples. And when we compare transdermal to oral, then we find that twice a week or thrice a week transdermal is fairly equivalent to once a day estrogen in most of its preparations. And the progesterones, today we find that the micronized progesterone and the dydrogesterone and even the LNG-IUS is much better than the earlier available medroxyprogesterone acetate. Contraindications I have spoken. And now, in the context of cardiovascular, we do understand today that oral estrogens should be avoided for women with hypertriglyceridemia or active gallbladder disease. These are women who have high risk of pancreatitis, and we need to avoid. Or if they have known thrombophilias, then in these women, transdermal estrogen is to be preferred. It should also be preferred for women with migraine and headache. The risk of venous thromboembolism, I'll come to it again. So therefore, this slide gets skipped now. Looking at a little bit exploration of the evidence. Now, whatever evidence from trials is available today strictly tells us that follow the timing hypothesis. The secondary analysis of WHI and other meta-analysis says that excess CHD risk appears to be confined to older women or those who are more than 10 years post-menopause. So case selection in WHI itself was flawed, and therefore whatever results are coming out of it still is skewed in favor of more risk for MHT. The lower baseline risk and moderate hormone replacement in women aged 50 to 59 resulted in no absolute excess risk in stroke. That was the conclusion. We will be looking at stroke risk later. There is a small but significant increase in the risk of venous thromboembolism, but the absolute risk is still extremely low. Other parameters, do they get affected when it comes to cardiovascular health? Let us understand that in well-controlled hypertension, it is very much possible to prescribe estradiol. Maybe transdermal is better. Transdermal may be better. Unlike in combined oral contraceptives, because whenever we have read and prescribed combined oral contraceptives in younger reproductive age group women, we are always told that it becomes medical eligibility criteria 3 and 4. Right, but here, well-controlled hypertension women can receive MHT with its minimal effect on BP, and it was evidenced in WHI and as well as the PEPI trial. Effect on body weight and body fat distribution, it is neutral or mildly favorable. So there is nothing to alarm for women that they will put on weight on MHT. Women on estradiol have some benefit, as was seen in the PEPI trial and the Rancho Bernardo cohort 650, a very famous trial where 15-year follow-up was done. It was the largest osteoporosis prevention trial so far. So the type of estrogen, what has been spoken of, the type of estrogen which has been spoken of in these trials, well, it is seen that either in especially in secondary prevention, that means women who have already had an event of coronary heart disease or ischemic heart disease, etc. In them, all the trials done so far, the WHI trial, the HERS-1, the trial, the ERA trial, the WAVE, Papworth, and WellHeart trials shows that there is absolutely no benefit. So in women who have already had a cardiac event or who score extremely high risk on all the ASCVD assessment risk charts, I think it will be better to avoid the hormone replacement, the menopausal hormone therapy. Estrogen in prevention of atherosclerosis trial, the EPAT trial, actually randomly designed 222 healthy postmenopausal women to unopposed oral 17-beta estradiol 1 milligram per day to placebo. And they checked the beneficial effects on lipids, and they found that there is a decreased atherosclerosis risk as measured by CIMT, but not with progression, but not with when it is added to progestin. So now the thing is, the decreased risk of atherosclerosis may be there, but it does not necessarily result in a clinical benefit of reduced events, cardiac events. So the decrease, this CIMT is, as Dr. Anantharaman already said, is a vascular parameter which can be measured by Doppler study of the internal carotid artery on both the sides in the neck, and that is the coronary, carotid intima media thickness. That is the ratio they calculate, and that gives a very good idea. It reflects what is happening in the heart vessels as well. This is a further evaluation of the trials which were done for cardiovascular illness, and they thought that unopposed estrogen and type of estrogen, is it relevant? And results suggest in these WHI, ESPRIT trial and WellHeart trial that neither unopposed estrogen nor a different type of orally administered estrogen is effective for secondary prevention. But an increase in CHD risk has been reported from combined EP therapy, as has been reported with combined EP therapy. That has been not reported with estrogen alone therapy. So estrogen alone therapy is still relatively safer than estrogen and progesterone therapy. All right, then there are some more descriptions here about the trials and how they were able to evaluate that there is no benefit. One of them is the women's estrogen progestin lipid lowering hormone atherosclerosis regression trial, the WellHeart trial and RCT. Okay, 226 postmenopausal women with established CHD actually. This must have been a very difficult trial to implement. Oral micronized 17-beta estradiol 1 milligram per day, either alone or in combination with medroxyprogesterone. And they found that after 3 years, either alone or with medroxyprogesterone had no significant effect on progression of atherosclerosis. All right. So they found that there was no progression of atherosclerosis in them. But as I have spoken earlier, most of these trials did not show a translation of this into clinical endpoint where they might have shown a significant reduction in cardiovascular events. So if the cardiovascular events are not getting reduced, then prescription of MHT for the purpose of cardiovascular benefit also does not exist. So whether we can give for symptomatic women under very close guide, supervision, we can give it to women who have excess risk of cardiovascular disease. But in women who have already had a call for angina, who have already had established cardiovascular disease, it may be better to avoid as of today. Now, the one molecule which still has promise is the transdermal estrogen, and this was the Papworth trial, 255 women already with IHD. and they were treated with transdermal for symptoms of vasomotor symptoms, and they found that it has more favorable effects than estrogen on markers for cardiovascular risk. They will also be less thrombogenic. When we say markers of cardiovascular risk, it may be the lipid profile also, it may be the the carotid artery evaluation also, and the calcium load on the heart also. Now, after 31 months of follow-up, there was a non-significant increase in coronary disease-related events in the transdermal group when compared with placebo. So it was not statistically significant. Nevertheless, it was there. So more and more, we are convinced now that please evaluate women for cardiac disease before well, so we come to the primary prevention and the timing hypothesis. Starting MHT soon after menopause may not cause harm, may possibly be beneficial because advanced unstable atherosclerotic plaques have not yet formed. So before the plaque disease has been established, there is a role for MHT, again, according to the symptom call. So in symptomatic women, when we are giving MHT, certainly, it may be beneficial for the cardiovascular system, especially in terms of plaque formation. So two WHI-HT trials, when they started closer to menopause, lower risk of CHD. WHI coronary artery calcium study, younger women 50 to 59 years, subclinical atherosclerosis as measured by calcium score, etc. It was lower in them. Then there is the KEEPS study, the Kronos early estrogen prevention study, women aged 45 to 54 years. So these are interesting studies because they are performed in younger women. Well, they saw that there is a lack of protective effect from whatever they did because of maybe low risk profile and shorter duration of trial, etc. But what has of great interest is the early versus late intervention trial. And this is in keeping with the philosophy of timing hypothesis. Early versus late intervention trial, the ELITE trial, 643 postmenopausal women stratified according to time, 6 to 10 years postmenopause, within 6 years and more than 10 years, received oral estradiol. No, within 6 years and 6 to 10 years, received oral estradiol and with or without progesterone. And they found progression of subclinical atherosclerosis measured by the carotid intima myoma thickness was slower in early, but rates of progression were similar to placebo in the late intervention group. So in early group, less than 6 years of menopause, yes, there is a benefit. Estradiol has no effect on the CT coronary artery calcium in either the early or the late interval. As I said, one parameter benefit is there, another one is not there. But early intervention seems to have some role in primary prevention, Again, the caveat is that please prescribe only for women who symptomatically need the MHT. And the primary preventive benefits are a parallel benefit. And that is not the prime reason for which we are starting the menopause hormone therapy. Some worry about increased stroke risk in women who go on to MHT. Whenever we assess them for ASCVD risk, it parallels with the stroke risk also, and therefore it will help us for case recruitment. The HERS1 trial, the WEST trial, and the meta-analysis of the HERS-West and WHO trial, what it all said was the oral estrogen therapy with or without progestin was associated with increase in ischemic stroke, but not hemorrhagic stroke or transient ischemic attack. And among women who had a stroke, there was a trend towards fatal stroke. So again, among women who have had a stroke, we will keep them out of the MHT pool. Then transdermal versus oral, low dose transdermal estrogen does not appear to increase the risk of stroke in postmenopausal women. So there is some benefit. Again, numbers are quoted. This is about venous thromboembolism. Yes, there is a marginal increase in the risk. I will just show you the risk chart instead of reading all this. But the mechanism is, one possible mechanism is an increase in activated protein C resistance, which is due to unopposed estradiol and also the combined estrogen progesterone therapy. Does the type and route of estrogen matter? Yes, transdermal has very lower risk of VTV, almost like the general population, because it bypasses the liver. And the oral estrogen in older women will have higher risk. Women who have prothrombotic mutation like factor 5 laden will have higher risk, who are obese will have higher risk. So VTV risk, right? Higher dose of estrogen, such as those used in oral contraceptive, will be associated. So that's the reason COC is not prescribed in much older women. In summary, there is small but significant increase in the risk of TE with current HT, but for healthy postmenopausal women, the absolute risk is extremely slow. Older age, obesity, 5 laden mutation may be associated with additional excess risk, but the risk does not appear to be altered by smoking, aspirin, or statin use. So it remains the same risk. I mean, everything is additive. Even if we stop smoking or aspirin, or even if statin is taking regularly, the risk does not go away due to MHT. The type of progestin, medroxyprogesterone is more of a culprit, and there are some comparative data here. 1 in 660 never users of hormone therapy at this age. It is the mortality from pulmonary embolism which has been mentioned here. If you look at the mortality from pulmonary embolism in that pool, then 1 in 660 were never users, and 1 in 475 were current users of estrogen only. 1 in 390 were current users of estrogen progesterone hormone therapy containing norethistone norgestrel, and 1 in 250 were users of estrogen progesterone containing medroxyprogesterone acetate. So as I said, the progestin matters. The progestin matters for VTE risk. Okay, all right. This is something which is more kind of understandable, and which is more concrete information, and which is actually kind of what Dr. Anantraman spoke again and again. So we better understand this. Is estradiol harmful for dyslipidemia? So if anybody asks you that, you can confidently say, no, it is not harmful. If women take oral estrogen 1 milligram per day, even CE conjugated, there is a proven beneficial effect as seen. LDL cholesterol decreases, HDL cholesterol increases, triglyceride also increases. Yes, I agree. Lipoprotein A levels decreases by 20%. Transdermal estradiol has lesser beneficial effect on the LDL cholesterol. Yes, that is one drawback with transdermal, but transdermal estradiol is beneficial for women where triglycerides are higher. So that is the difference with transdermal estradiol. Secondary prevention of CHD, no benefit from all the trials. Women with dyslipidemia, when they take estrogen progesterone along with statins, a small decrease in LDL cholesterol is seen, and elevation in HDL is seen, and reduction in lipoprotein A is seen. An increase in triglyceride is seen, which if you add the statin, it decreases. So hyperlipidemia and coronary heart disease, MHD, no role for secondary prevention, and statin should be the first choice for lipid-lowering therapy in most women with CHD. So though we know that estradiol is going to reduce LDL cholesterol, it cannot function as a primary molecule for lipid-lowering therapy. The primary molecule always remains statins as the first choice. Estradiol will be prescribed to women with dyslipidemia who have symptoms of menopause, and this is a parallel benefit which can ensue, provided there is no active coronary heart disease. This is more information about the effect of progesterone on on the lipids, and this is a little heavy because we already said whatever we wanted to say. That a reduction in serum total cholesterol concentration is there, reduction in LDL and elevation in HDL is there with both estrogen and estrogen plus progesterone. Yes, but the benefit is more with micronized progesterone, has a better effect on HDL than other progestins. The effect on triglycerides, tendency to raise as much as 24, although small, 24 to 29% with estradiol. Whenever you combine it with progestin, especially micronized progesterone, the effect will be a little less. Now, transdermal does not raise the triglyceride. All right, so then having learned about all the evidence, we come to the business of writing prescription. And when we have assessed the risk scoring for cardiovascular disease, and just as we spoke about the other contraindications to be ruled out, and we need to plan for the woman who comes to us with symptoms, with or without uterus, and with other comorbidities and other gynecological problems, and we assess the biochemical and parameters and the biophysical parameters, and then we prescribe MHT as we have spoken in the previous segments, which molecule to give, how long to give, etc. And when we follow up again routinely, all gynecologists are very savvy about follow up today. We look at all the parameters, we do cancer screening as required, and we also do the atherosclerotic cardiovascular risk assessment. Of course, the bone assessment is also there, and we make sure that there is adherence to parallel therapy and to lifestyle as well. So this is what I wanted to say. And I now invite Revati Madam to share so that we can finish this segment and then take the questions and then go on to the last one, which is for the exercise. Yeah.
Thank you, Dr. Shobha, for sparing few minutes for me. Now, I had an opportunity to listen to Professor Dr. John Stevenson of UK during the last World IMS Congress at Melbourne. He was a consultant endocrinologist, highly experienced with a special interest in prevention of coronary heart disease and management of menopause. His topic was MHT for the prevention of CVD. It was quite interesting. I thought it can throw some light on future possibility of prescribing MHT for CVD prevention. And he has established first female heart disease clinic also. Now, I'm just reproducing his own slides. HRT and MI survival. He has found that more than 1 lakh women with confirmed MI has found that the percentage of death was higher in very, very high, nearly double with the non-users than with the HRT users. And again, age-wise, as we all know, the timing hypothesis, the CHT death was again less than 60 years, it is much less, and more than 60 years, it is high. And this is a very important slide he showed, microvascular angina. This is angina with no obstruction of major epicardial arteries. This is a coronary microvascular dysfunction where there is a failure to dilate appropriately or there may be a spasm. It affects women more than men, especially around the time of menopause. Of course, it may coexist with macrovascular disease also. Now, the problem is that this microvascular angina is very difficult to make a diagnosis either by the angiography or a coronary flow reserve or a cardiac MRI. And the treatment is ranolazine, long-acting calcium antagonist, and estrogen also. And all of us know the estrogen and arterial function, how it helps, like restoring the nitric oxide dependent endothelial function, endothelial nitric oxide synthase protection, inhibits calcium channels, reduces AC activity, and so many benefits of estrogen on arterial function. And he concluded saying that CHT is a major disease for women. Totality of current data indicates that HRT is beneficial for prevention of coronary events. And the benefit may depend upon three things. One is the type of the hormones, particularly the progesterone, dose of the hormone, age at initiation of therapy. Menopausal HRT must be considered differently than other medications since no other single primary CVD preventive therapy offers a diverse systemic-wide benefits. So major primary prevention measures are smoking cessation, weight loss, blood pressure reduction, regular aerobic exercise, diabetes control, repeat, all those things that what Dr. Anantaraman was describing. And the practical CVD suggestions at the end, he put nicely that postmenopausal women, premenopausal women. In postmenopausal women at increased CHD risk, they may benefit from HRT. He says that just try to find a reason to prescribe that. Definitely they are going to be benefited. And they may relieve cardiovascular symptoms like angina, palpitation, etc. And of course, start with the standard dose if they are less than 50 years, low dose 50 to 60 years, and more than 60 years, ultra low dose. And again, he says that in premenopausal women, cardiovascular symptoms like angina, palpitation, disease, all these things are often related to the menstrual cycle like PMS. Even those patients, a top-up dose of estradiol, either a form of patch or gel during the luteal phase, may definitely prove beneficial. So various studies have shown, and he has shown that development of substantial CVD risk after menopause provides a window of opportunity for extension of cardio protection from endogenous estrogen in postmenopausal women with hormone replacement therapy, that is MSG, as a sex-specific primary preventive therapy for CVD and reduction of all-cause mortality. I think that after hearing his talk, I thought that the day is not far away to make it a recommendation to prescribe MSG for prevention of CVD. Thank you. This is what I heard.
Yeah, thank you, thank you, Revati madam. Thank you, Revati madam. So we are kind of looking at still a very fluid situation where that kind of recommendation is not still there. So on our platforms, we are still saying that,
Yeah.
MHT is for symptomatic
Yeah, yeah.
women and
Yeah, yeah.
for GUSM. Yeah.
I just want to
But
share that
then
in
whatever it
future.
is, definitely there is a parallel benefit for primary prevention.
Mm.
And we are getting more and more convinced every day. So I think I did not see Manjula has written, yeah, Manjula has just appreciated. She has asked, mood disturbances, will MHT suffice or COC are the best? No, no. Whenever women have menopause symptoms of menopause, like hot flushes, vasomotor symptoms, then MHT is the best choice and not COCs. COCs are for a very small cohort of women who are premenopausal, perimenopausal, require contraception very strongly, and also have some symptoms. In them, we can give low dose COCs if they fit into medical category, medical eligibility criteria 1 and 2 under strict supervision. And usually 45 to 50 years only, after that we do not give them. So between 50 and 60 years, definitely it is MHT only. So that is a good question because many people are confused about that. Revati madam, I think I'll call the physiotherapist next because she's waiting to demonstrate working with Dr. Anita. Shall I move forward with the last segment?
Yes, yes. They have to.
Yes, yes.
Yeah, thank you. So now I request Dr. Veena Nambiar. She's. Can I have her CV, please? She is the head of physiotherapy at MS Ramaiah Institute of Medical Sciences, Research and Medical Sciences. She is Professor Department of Physiotherapy, Chief of Cardiac Rehab Program, Center for Rehabilitation, Ramaiah Medical College and Hospital. Dr. Veena Kiran Nambiar for you. Of course, her qualifications you can all see, PhD, MSc and PGDMLE as well, and I have a very dense work experience at Ramaiah Vivekanand Institute and Nanavati Hospital, Mumbai. So welcome, Veena, and you can share your screen, and I request Paresh to highlight her screen so that we can all see the workout. Thank you.
Yeah, thank you very much, ma'am. I'm sorry because I don't have any presentation because this was a very last time thing.
Yeah.
So
No, not expected. Not expected.
No problem.
Yeah. Please
so
start.
I'll just quickly brief about a little bit about exercise, and then we'll just demonstrate some of the exercises which is very much necessary in menopause women. And I'm a visiting scientist to Toronto University at Rehab in Toronto. And there in cardiac rehab program, we have almost 200 women who are enrolled in women cardiac rehab. And most of the most of the women there either come with postpartum issues of heart failure, or they are into menopause issues, having long-term heart failure. So considering the risk is so high, and it is actually a segment we totally ignore. So, and I think in India, I don't know how many really visit, to come for an assessment for a menopause woman. They actually, deal with it silently. And all our previous Dr. Anantaraman also spoke about, all the things which happen in this people. So definitely it has an effect on the cardiovascular system, the bone health, and definitely the mental health and psychological health of the person. And bone health, because of lack of estrogen, there is more of osteoclastic activity than osteoblastic activity. And so that's why we tell that exercises is very important. And moment women thinks that, oh, strength training is to build muscles. No, it is not to build muscles. Because again, exercise is what we do. It has to be prescribed. It is a prescription. Doctor usually tells them, okay, go and walk. But they don't know how much they have to walk, when they have to stop, what are their safety limits. They don't know about that. And it is up to us to educate them what are their safety limits in terms of their heart rate, your perceived exertion, and other vital parameters. Exercise definitely improves their physical, mental, and psychological well-being. Before having this person coming into us, always is necessary to have a proper assessment. Assessment involves your vitamin levels of the person, because you'll have the vitamin D and B12 sometimes being affected. And strength assessment has to be done, and then balance assessment. Many of them will be in their older age group, so maybe around 55 or something like that. So balance is very important. Their aerobic capacity is important. So you need to evaluate all this, the physical components, even the psychological components, and mental health has to be evaluated in case they need to be referred to a psychologist or a counselor that is required. So when we talk about exercises, definitely it has to be tailored for everybody, because they would be having a lot of comorbidities. They would be having cardiac hypertension, diabetes, some of them may be having osteoporosis. So it has to be tailor-made for every patient, and there should be an exercise prescription. Exercise is no longer like just go and walk, because it has to follow the fit principle. How much you have to exercise, what's the duration, what is the frequency, what type of exercise you are supposed to do. So it all matters. So when you do an exercise prescription for these patients, usually you start with, should be about 45 minutes of exercise, and it starts with the flexibility and stretching. You have an endurance component, you have a strength training component. Definitely Dr. Anandram spoke about sarcopenia. Statins, prolonged usage, we have seen patients coming with sarcopenia. You can do only exercises, and strengthening takes care of that to a certain extent, and there are even studies done with that. You need to do endurance training exercises for about 3 to 5 days a week, and see that your physical fitness, physical activity is about 150 minutes per week. But these are all basic, when people count their steps, 10,000 steps, but 10,000 steps is not the Bible. 10,000 step is something very regular. But what you do other than this that is your exercises. And so then you need a structured program, you need strength activities, you need balance activities, endurance activities, and see that the women, they give at least a half an hour themselves for them to exercise. And even when you're exercising these patients, because since we're talking about cardiovascular health, you don't know what is their target heart rate. You have to calculate their maximum heart rate when they're doing that particular exercises, and you have to see the percentage of intensity. Directly, I'm not going to start the person on 80% of the maximum heart rate, because I have to do a prescription, the assessment, and see what is the risk factors, what are involved. Depending on the risk factors, I'm going to tell whether I start with 50 to 60% of the maximum heart rate, or 60 to 70%. So this is the target heart rate range. And you have to perform in this range, otherwise you cannot overperform or underperform. That means it's not optimal. So that's why your exercise prescription is very crucial. When the person goes home also, you tell, okay, you do push-ups, so you do whatever exercise you do, but see that your heart rate remains between 110 to 125, or whatever is your target heart rate range. We failed to do all these things in actual practice, which is very important. And that's why, because if we're considering cardiovascular risk, it is necessary to monitor all these in the beginning, and also to tell the person how to monitor at home using the pulse oximeters and all those things, or a polar belt, or everybody has smart watches now. So now I will just quickly demonstrate with one of my staff the basic exercises, which they can do it anywhere, although it doesn't underpin that it needs to have an assessment, an outcome assessment, which has to be done pre and post, because if you have to do it scientifically and objectively, you have to do all those. Yeah, so just give me a second. Okay, can you all see her?
No, we can see the feet. We are not able to see.
Now?
Yeah, now it's better. Yeah, now is okay. Yeah. Yes.
No, I lost it again, right?
Hmm. A little bit lower, please. Yeah, now it's okay. अभी ठीक है मगर थोड़ा सा टेढ़ा. हाँ. Little bit lower. There is a yellow band which is coming below. हाँ. Little higher. Not higher. I mean lower. I'm sorry. Now it's perfect. Yeah, perfect. Perfect. Yeah.
So this is my cardiac rehab OPD. So we have all patients. We have cardiopulmonary patients, women for cardiac rehab, pediatric, and everything. So let's start with the first exercise. This first exercise is I'm going to make her do heel raises because this is going to bring about an increase in her, the calf muscle strength. So please do heel raises. Do about 5 times because these are simple things which they can do it anywhere. Okay. The next one you have to do squats. Usually prefer that you do half squats in them. You don't do complete squats because complete squats will, it will injure their knees. So start with half squats. This will improve the firing of your glutes muscle, your hamstrings, and your quadriceps. So start with half squats. Ensure that your back is straight up there. Now let's do forward lunges. Yes, see that your knee doesn't cross the toe level. It has to be 90 degrees. It should not cross the toe level. Come back. Do again. Come back. Do again. Okay, now let's do side lunges. Yeah. Yes, stop there. Yes, come back. Do the other side. All these works on your core also. When you focus on exercises, you have to do upper body exercises, you have to do lower body exercises. Also your core. Core is a very neglected area, especially your core, abs, and your pelvic region. Where maximum, because menopause, you tend to put a lot on weight, and all this weight is around your core, abs, and your butt. So we need to strengthen those muscles if you want to have a very strong back. Then we'll do wall push-ups. Yeah. Come back. Push. Come back. Push. Come back. Okay. Now let's do step up and step down. Yeah. Step up, come down. 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 Okay. Now we will do plank. Plank is considered as very good for the entire body. It improves your core, your upper back, and your entire lower back. So the more time you're able to hold your plank, that means you're good. So you have to count 1, 2, 3. You have to count how much over 30 seconds, how much minutes your person is able to hold the planks. Yeah, come down. The next exercise is bridging. Bridging is mainly to activate your glutes, your core muscle group. So you have to hold it up there. You have to count for 5 seconds, and then you have to go down. Yeah. Up again. Take it up, hold the bridge. Come down. Once again. Hold it, squeeze your butt, hold it up there, and come down. Okay. Now next exercise we are going to do is kickbacks. Kickbacks is also for core, and it is also for your gluteus maximus to activate it. Most of the time you see women don't activate their glutes. The glutes doesn't fire, they have piriformis tightness. Yeah. Come back, do the other leg. Yes. Yeah. You can make these exercises more hard by you can tie a weight on your ankle. So these are basic exercises because there are a lot of variations you can do using dumbbells, using TheraBands, TheraTubes, Swiss balls. There are a lot of variations, so you can do it suiting to whatever is available around with the person. You can do that. And then one more exercise which I will show is the back dips of your triceps. So can you do this? Yeah, come up. Triceps in women, triceps is first to lose weight around the triceps is very difficult in women. Okay, so we need to build this up. Very good, go down. Yeah, come up. Relax. Okay, so these are the exercises which we could do it.
So do you recommend aerobics for cardioprotective
Yes,
exercise? Yeah.
yes. We have to do a combination of both endurance as well as strength. Both are important. We usually neglect the strength, but endurance is very important. We can do
What
both.
you showed just now was strength, no?
Yeah, it is mainly strength, but then we can also have we can also do cycling as an exercise. And cycling we can do climbing of stairs. Walking itself can be done as a
Correct.
walking
So
itself can be a
correct.
prescription because you have to tell the person how much they have to walk and for how long they have to walk.
It's a good idea to write it down, right, and give it to them. Correct.
Yeah, because we have to tell them, okay, if you have walked for so much distance, so then you have to stop. You have to see what is your
Correct.
perceived exertion. You have to give them the safety limits because they can't just keep walking.
So any questions are there for Dr. Meena? Anything else, Meena? Would you like to convey anything else? Those were very interesting, especially the biceps, triceps. I think people were not that much aware. The core exercises, to some extent, we were aware,
Core
but
is the fundamental.
the bridging,
Fundamental.
the bridging. So does it help in cardiovascular this thing also, benefit also?
Yes,
The core,
because
yeah.
see, again, what happens, whatever exercise you're giving, right? It has to be within, there's something called as Carbonen's formula. Right, so you have to measure your target heart rate range and see that you're optimizing your workout. You have to be working out in that prescribed range of your heart rate.
So when we are prescribing the exercise, see, we have to know many times the patients say, no, I cannot do it. I have got pain. I have got this, that, or even for simple walking, they say that they have got knee pain. So they try to find an excuse. How to motivate them? That is very important for us. To start with smaller ones and then slowly.
We can.
Yes.
What is Paresh? Can you stop the highlight now and we can have the normal view because. Yeah, it is an individual thing. Yes. Yeah.
Because motivation is very important. Actually, in our setup here, we have made it like a very informal setup, right? The patient should feel good. Person should feel good when they come to you. We need to have some visuals put around. We should have some music on there, and they should be fed like it's normal, right? So then we talk to them. So little bit CBT is also required here. That behavioral therapy, a little bit of those things are also required. So wherever we feel that the nutrition is not correct, we have to send them to the nutritionist. So it's a combined thing of everything actually.
Correct.
And most of the patients who come, most of the people who come, they tell that I do exercise. I said, what do you do? No, in the house only I keep active. I'll be so busy. I said, that becomes your daily living. Don't mix exercises with your activities of daily living. Right? So they need to understand why. And when they start seeing the benefits, right, then they get into that mode.
So questions are coming up, how to calculate target heart rate and first you tell that.
There is a formula for target heart rate range. It is called as Karonen's formula. If you Google, you will get it. Carmen's formula basically, for that, you just need to know the resting heart rate and the maximum heart rate of the person. The maximum heart rate is 220 minus age. And you substitute in the Carmen's formula and then
Yes.
apply. Then you have to apply this, because this is not easy, because it comes with years of experience and how much the risk the patient is having. I have to calculate that risk. If the patient, depending on all the other comorbidities, diabetes, hypertension, whatever they have, I have to calculate whether this person is having high risk, medium risk, or low risk. So depending on that, the percentage of heart rate is calculated.
And normal postmenopausal women, what is the ideal time of exercise recommended per week? I mean, they want to know the duration of
Duration
exercise.
should be anywhere between 30 to 45 minutes. Max 45 minutes, not more than that.
Per session, no? Per session.
Per session. And when they're doing strength training,
Ideally, if you feel this should be cardioprotective, then it should be as you showed, a core building, which is some of the movements are yoga movements in that, plus
Correct.
whatever you showed. Resistance also can be mixed in that, right?
Yes,
And
yes.
then you showed the, you said the aerobic part, right?
Yes.
So even walking can be considered as
Yes.
an aerobic exercise. Dancing can be considered, and
Yes.
jogging,
Zumba,
stair
jogging.
climbing, you
All
said.
Shobha,
Yeah.
all her movements were in their dance only. The leg movements and
Correct.
Yeah, but what happens in
Yeah.
dance, then it becomes like an aerobic activity. It's an endurance. But strength, whatever I told you, it has to be done with dumbbells or therabands or therapeutic, because you have to target the specific muscle mass. You know, so today, if I decide I have to do my legs, so I focus on my quadriceps, glutes, and my hams. Today's session is only that. I do about 5 variations. Each variation about 3 sets of 12 to 15
Correct.
reps.
So you do recommend, no? You do recommend
Yes.
that per day you target once.
Yes, one big group of muscle. And because that next day I will not do that, because I have to give rest to those group of muscles. Third day, next day it will be core. I focus on core. So it has to be alternated. Like
Somebody has asked morning or evening. That's very
so it
cute.
doesn't matter. It doesn't matter.
Whenever you get time.
Yeah, doesn't matter.
But should do. That's all.
Yes, that's all.
Okay, then somebody has said, Dr. Shakuntala, that walking on treadmill is advisable, especially during rainy, because you can't go out. So if you're doing it on a treadmill, then what is the duration? Something.
See, again, treadmill, the duration is again, when I prescribe it, I have to see that how much is the intensity I'm targeting for. I'm targeting for 100 to 110. So I have to give it for 10, 15 minutes, because after that, probably I do some other activities. So I have to schedule my whole half an hour into different activities. So I have to divide it. Like, it is just not treadmill. I have some stretching exercises,
Correct.
strength. So it has to be, tailored like that.
Correct. So we must pray also every day that today you should give us adherence to exercise. You should make us do the exercise, because I think it is a huge motivation for each one of us to do that. And I have often, as a point of, sharing my own thought and experience, I have often asked my cardiologist, etc., and the team who does the treadmill for me, that why should I come and do the TMT? Because my own patients ask me, why, ma'am, you're advising me annual TMT? Because I'm already going for walks this much. So then my cardiologist told me this is a gradient, whereas walking and home treadmill, there is no gradient. So here there will be a gradient which will check your ECG changes, and every few seconds that gradient will up. So please don't miss your annual TMT, even though you may be performing extremely well in home exercise without any breathlessness. So please don't take that as a treadmill test. So that was the
challenge. You have to challenge your body. You have to challenge your muscle. Muscle is an organ. So it's no longer like the old thing. Muscle is an organ.
And then the cardiac monitoring should be there. The ECG trace should come with that. So it's better. So I think today this is all we had to give our audience, and we are very grateful that at least still 50 are there around. So Anita ji, thank you so much for giving us the opportunity to conduct this. Very
Shobha,
grateful
for organizing
you.
such a wonderful prescription writing webinar. And
Thank
all
you.
the speakers did their best. And I am sure that all the listeners must have received the very, very crisp and informative messages, and that will be definitely helpful to all of us.
Correct. And it's a
Thank
work
you
in
very
progress.
much.
I think prescription writing will come with time. We evolve in every session. We can show them more prescriptions, etc. But today I'm very
Right.
grateful that you gave me the time. Yeah, thank you.
Thank
bye.
you. Hello Shobha. Hello Janki ji.
Hello, hi Aarti, hi. अच्छा लग रहा है देख के.
कैसे हो?
Good. Going on.
Okay, goodbye to
Shakuntala has
everyone.
given us, Tejavati has given us compliments, Shakuntala has given, Charanjit Kaur has
Yeah,
given,
everyone has
Shubhangi has
given
given.
compliments, Shobha.
Thank you.
Waiting
अरे नहीं,
eagerly for
सबके लिए.
next month
Suman
planning.
also.
Yeah. Next
Yeah,
month we
we'll do
will
that.
send the flyer a little bit earlier.
I will do that. I will do that.
Yeah.
करेंगे
So
करेंगे
that
जरूर
more and
करेंगे.
more people can join. Yes.
Yes. We'll do that. We'll do
Okay.
that. Thank you very much.
Okay.
Just wanted to inform everybody that Dr. Anita as president and Dr. Ragini as secretary have given permission for a handbook of this prescription writing sessions. And we will try to make a very crisp handbook so that it remains on your desktop and you will be able to read. So try and access to that. And we will also try and make it accessible for you. So thank you, Anita ji.
Yes.
Thanks a lot.
Yes. Okay.
Thank you. Bye-bye.
Bye.
Bye, Aarti. Bye, everyone.
Hello,
Yeah.
Reena ji, namaskar.
Thank you, Shobha.
Hello,
Bye,
Chaitanya.
Reena.
Thank you,
Very
Reena.
nice,
Thank
Yemi.
you. Thank
Bye,
you. Thank
Chaitanya.
you.
Yeah.
Bye. Bye.
Bye-bye.
Veena Nambiar, thanks a lot. And we saw Chaitali Kadam on the phone, so I was not recognizing that. So that is why I took time to
आप
know
म्यूट
that
हो
you are there.
चैताली, म्यूट हो आप.
नहीं मैं चैताली वीना.
She is Veena.
I'm Veena.
Veena is
So it
very
was
sweet.
lovely having you. Yeah.
Veena is
And
very,
she's
very
so
sweet.
good. Yes. And she's so good in the subject, my God. Okay.
Yeah.
So we look forward to more sessions from you, Veena, in future.
Yes.
So let us then get on with our everyday business and let us not miss the exercise.
Yes.
Sitting in front of laptop comes in the way of exercise. Bye then.
Bye.
Bye-bye.